السلام عليكم. كل سنة وانتم طيبين، رمضان كريم، وشكرا للدكتورة إيناس والجمعية العربية دايما في المقدمة ودايما مشرفانا باكتيفيتيز على مستوى المنطقة كلها. Today my lecture is about the new updates from the 2021 guidelines. I'm sorry, there's a typo error. It's not 202, it's 2021. And I'm delighted when I was watching the sessions to see that many of the speakers are already adopting some of the slides that are available from the guidelines. So I don't need to tell you, I mean, there's many discussions already been mentioned about the decision of fasting. The decision of fasting is a multitude of a number of things: a medical decision, a religious decision, as well as a personal choice. And the three are very important. This has been well covered. Everybody knows the classic risks during Ramadan. And people are very familiar with this table that was from the last guidelines. It was very popular, and indeed it helped many people. But the reality was that there was plenty of publications and plenty of reality that maybe the tables are a bit rigid. For example, if I were to go back to the table, it will show type 1 into the very high or high, and the advice is must not fast or should not fast. Many people with type 1, in fact, the data from Egypt, which we did last year, 67% of type 1 diabetics in Egypt do fast. And the same would apply to many of the others. So how can we select the right patients? And indeed, this was the concern of some into many other recent publications. The reality is you need to think of a number of factors that makes you make the decision. When you're sitting in your clinic with your patient in front of you, you have a number of factors. Some of them are related to maybe the conditions of Ramadan for this particular person. Many are related to the diabetes that the person has or the treatment that the person has. And then finally, some of the points are related to the individual himself or herself. So I would like to share with you one of the important points. This is a study that we did on glargine 300, 500 persons, only 25 from Canada. All the rest are from the Middle East, India, or Pakistan. But the rate of hypoglycemia in Canada was 24%. Versus 1.3% in the other regions. So clearly the circumstances of fasting, the hours of fasting, and perhaps in our countries, in Egypt, for example, the working hours are modified that it's Ramadan. That's not necessarily the case everywhere. Type of diabetes, as you can see, type 1 diabetes, 30% decide not to fast. But that means that 70% decide to fast. If you look into hypoglycemia, why they do so? Because 62% of people with type 1 diabetes develop daytime hypoglycemia. This is data from the latest survey that we did on nearly 8,000 persons globally from many countries, including Egypt. So can they fast safely or not? Well, as I mentioned, some do not fast. But there are some who fast the full month and some fast with no hypoglycemia at all. So it is difficult to say for all type 1 diabetes no, and equally it is not right to say for all of them yes. We have to be very selective with our choices. The same with type 2 diabetes. You all know that insulin increases the risk of hypoglycemia. Some sulfonylurea also do so. So the risk of hypos is also related to the type of therapy. And that is something that you need to take into account. Crucial factor is previous hypoglycemia rate. This is data from a study that we did called CREED study. Here is the odds ratio for hypoglycemia during Ramadan if you have hypoglycemia before Ramadan. That makes the person very likely to have hypoglycemia, even more than the difference between insulin and non-insulin treatment. So this is really quite important as well. What about complications? We have a number of small studies on patients with complications, cardiac problems or renal problems. We did in these studies optimum care with education, best insulin, dose adjustment, and flash glucose monitoring. Events were not high. Risk factors were not worse, but what was clearly worse was hypoglycemia in patients with stable coronary heart disease. So it is important to take all that into consideration. What about age? Should I say to someone who is of older age, do not fast? Well, the data are saying to us that obviously people with older age will have longer duration of diabetes, and more of them will automatically decide not to fast. 29% here decided not to fast where their age was above 65, compared to 12.7% of patients on type 2 diabetes. And the rates of hypoglycemia in the older age was 2.5 times higher. So you must consider age as one of the factors as well. But then come to the point. The same data says that people with older age, that many of them did not have hypoglycemia. So how can we dissect the information? How can we look into, for example, types of insulin? Here is data on basal insulin versus intensive insulin. Of course, the type of therapy, intensive insulin, will put the person into the risk of having more hypoglycemia, longer duration of hypoglycemia, particularly between Zuhr and Maghrib. So here is the risk score. Now, the beauty of the risk score is it unifies the process. If I would today as a patient ask the opinion of Dr. Amr, and then Dr. Ines, and then Dr. Sandid, and then Dr. Abdul Khaliq, perhaps everyone will have a different opinion. As a patient, this is very confusing. But applying a systematic approach would be quite helpful. The systematic approach takes into consideration the type of diabetes, the duration of diabetes, the severity of the hypos, the awareness of the hypos, and the frequency of the hypos. The level of glycemic control. Am I well controlled, moderately controlled, or poorly controlled? What type of therapy am I on? Am I on mixed insulins? And you will see here that mixed insulin scores more than basal bolus. Why? Because of the rigidity of the mixed insulin versus the flexibility of the basal bolus. You look for the complications, chronic complications and acute complications. Are they there or not, and how aggressive they are? Are they stable or unstable? The renal function, how aggressive is the deterioration in the renal function? DKA and HONC. And then pregnancy. Well, you see that pregnancy is the only one with an asterisk. Why? It says here, pregnant and breastfeeding woman. This is automatic. Every Muslim knows, and if they don't know, it is written that the lady is exempt from fasting, regardless of whether she has diabetes or not. But we know that some insist on fasting. So if they insist on fasting, what should you do? Then you need to apply a clinical scientific basis score. Monitoring the blood glucose is very crucial in Ramadan, and that is something that we need also to factor in. And then come some of the important aspects, such as duration of fast, the intensity of the job, the cognitive function of the person, as well as the frailty of the person. And we had to put some sort of age, but we didn't put age on its own. We put age with no home support. Of course, there will be plenty of people above the age of 70 who are very fit and independent. And you will then, in the risk score, ignore that point, ignore these 3.5, because the individual in front of you is a fit, healthy 72 or 75 years old versus someone who is much younger, but still frail or not healthy. And then finally, the overall experience of the person from the previous Ramadan. And with this, as mentioned by the previous presenters, you end up with a score of 0 to 3, 3.5 to 6, and above 6. The importance is to have harmony with the religious authorities. And alhamdulillah, we have the fatwa from Dar al-Ifta al-Masriya, the highest religious authorities. Whether we agree with it or we don't agree with it, from our clinical perspective as clinicians, this is what we as clinicians says, high, moderate, or low. Now, the fatwa is based on two important aspects: avoiding hardship and eliminating harm. Avoiding hardship اللي هو باللغة العربية القدرة على الصيام على الذين يطيقونه. Eliminating harm احتمال الضرر. Of course احتمال الضرر دي نقطة مهمة جدا، لأن القرآن والحديث الرسول عليه الصلاة والسلام كلها تدعو إلى حماية ولا تلقوا بأنفسكم إلى التهلكة، وكثير من الأمثال إن الله يحب تقطع رخصه، كثير من الأحاديث والآيات اللي من القرآن والسنة. So what we need to do, you need to, before Ramadan, assess your patient. Put every element sequentially, apply it sequentially, one after the other. You will end up with a score. And then you can see with your patient if these scores are modifiable. If my glycemic control is not good, maybe you will intervene and get it better, or I will intervene as a patient and have better control. Frequency of monitoring. There's a number of factors that perhaps could be modified, and then you end up with a score. I'm delighted that, alhamdulillah, and you are the first meeting to have seen this slide. You can now download the application for DAR Academy, which is meant for healthcare professionals. With it, you will see here the risk calculator. When you click on the risk calculator, you will end up with this page, which will take you to the chapter from the guidelines which identify this and some of the important aspects. And then you click start now and you will get the score, and you will be doing it within less than a minute. You will complete the score and you will come with a result. I hope that this would be a very simple, straightforward method that will help all of us to have a systematic approach in quantifying for our risk for our patients. So, Mr. Chairman, ladies and gentlemen, fasting Ramadan is obviously a religious obligation for healthy adults. However, the Islamic regulations are clear and illness is exempt. Our job as healthcare professionals is to identify who is ill. In the past, we had a table. This person, yes, this person, no. The reality was different than the tables. So what we tried to do in this latest guidelines is to put multiple clinical elements with a score that can guide us a bit better. And alhamdulillah, that has the approval of the Mufti of Egypt. Of course, it is not Quran. This is advice from clinicians. And you as a clinician, you can look into the points and you can say, my advice for this person is not to fast because of 1, 2, 3. You are the physician and you are the person who take that decision on the behalf of your patient in collaboration with the patient, of course. And here are the references for my presentation, and I would like to thank you.